Hi everyone, I am Dr. Diksha Pandey, Additional Professor in the Department of Obstetrics and Gynecology and looking after the subdivision of Urogynecology at KMC Manipal. And we have another interesting case of prolapse with some things which we'll discuss. It is not just a kind of prolapse, but it is very important message which we should all learn in our clinical practice. So Dr. Mrudhula, who is a junior resident in our department, will be presenting the details of that case. And to discuss the case, I have with me, as always, Dr. Richa Choksi, who is an assistant professor in our department. So, start with it.
I'm going to present a case of 74-year-old Mrs. X who is hailing from Udupi, who is referred to our urogynecology clinic with complaints of uterine prolapse. And on asking the patient, she complains of mass per vaginum since 15 years. She also complains of difficulty in passing urine since 6 months, for which she went to different hospitals outside, and they treated her with tampon and uterine reduction, and then with catheterization, and her symptoms did not decrease. And she also complains of urinary incontinence and poor stream of urine since one day, for which she has come here today. And patient also complain of mild suprapubic discomfort and nil urine output from one day. And she is nil comorbid, no known comorbidities like hypertension or diabetes. And on asking for her surgical history, she mentions that she has some right inguinal lipoma, for which she was treated in the outside hospital, and they have done excision of the lipoma. And menstrual history, she is postmenopausal for 30 years. And obstetric history, she is
Can I stop once, Mrudhula? I'll just ask one thing. I'm just curious to know why a prolapse case was referred to us. Usually, people think that prolapse is a simple, like gynecologists have been doing prolapse surgery for 100 of years, and everybody thinks that it is a simple procedure. And why did they refer her specially here?
Wherever she has gone, ma'am, they have not done any, they have not given the advice for surgery. They have only asked for reduction of the uterus, and they have just treated symptomatically by placing catheter in situ. But it was not evaluated like for what is happening to the patient, or why she having continuous complaints, and repeatedly she was going to the hospital. And with these complaints, she has come here.
Maybe she was not seen by a gynecologist,
Gynecologist.
so
Yes,
she was
yes.
going to urology or surgery.
Because this has happened last year also. We had some patient who presented with like Procedentia and incarcerated kind of prolapse, and then very educated kind of patient. And when we asked them, they said that they have gone to various places. They were in transferring job, and initially when the prolapse was first degree, second degree, they had gone to various places, and everybody said that it is part of, like, maybe they have not met a gynecologist properly, and everybody said that it is part of aging. And so patient also lost faith in going to the hospital. So she was embarrassed, she did not go. And last year when she presented to us, she had already incarcerated prolapse. So this is one very, I cannot understand kind of practice which I have been seeing. So,
In obstetric history, she is para 2 living 2 with previous 2 normal vaginal deliveries. And personal history, she has been having normal bowel habits and only difficulty in urination. And on examination, her general condition was fair, and on palpation, lymph node was supraclavicular and inguinal lymph nodes were not there. And uterus, no cyanosis, no uterus, and no pallor. Vitals were stable. Her BMI is 22, and on examination per abdomen, it was soft, non-tender, no scars were there, and there was no suprapubic tenderness. On local examination, perineum was urethral meatus was normal. There was laxity of the perineum, and catheter was in situ. On examination, when we asked the patient to cough, and with stress, the prolapse has come out, and there was procedentia, complete prolapse has come out, and there was grade 3 cystocele, and even there was rectocele, and minimal bleeding was present through the os, and there was keratinization around the os, and with bluish discoloration, and no decubitus ulcer, and cervix was looking healthy. And we have taken one pap smear. Prolapse walls were thick and tough, and I could palpate above the fundus of the uterus. And prolapse was reducible.
Procedentia.
Yes, it was procedentia. And prolapse was reducible. On pervaginal examination, after reducing the uterus, cervix was flushed with vagina and there was no adnexal mass felt. And on perrectal examination, parametrium was free and mucosa was also free. No obvious mass was felt. And she was stable. And we have advised her TVS, and we have also advised her basic investigations, and we have also advised her CA 125.
Why did we advise CA 125?
To rule out any ovarian.
Are you thinking any ovarian? Okay, tell what was the ultrasound you have done. Let's discuss this story first, then I'll ask you questions.
Ultrasound done showed thick ET of 14 mm.
14 mm.
14 mm.
And what is the cutoff or approximate cutoff?
4 mm.
4 to 5 mm.
Menopausal
Yes.
women, it is 4 to 5 mm.
Yes. Some studies say 4 mm, some studies say 5 mm. So it was much thicker. It was 14 mm.
And on examination, there was also bleeding through the os present, which I have mentioned.
Yes.
And
you specifically said that bleeding through the os was present. But there was no decubitus ulcer.
Yes.
In prolapse, whenever there is bleeding, we think that it is because of ulcers. Yes.
But did this patient present sometimes with history of bleeding?
No, ma'am. After seeing like through the os, asking retrospectively, she mentioned that there was intermittent bleeding from 1 year, intermittently, for which she was not evaluated anywhere.
So this is, Mrudhula, this brings us back to the same question that it is very important to take a meticulous history. Okay, so if we take the history as we have described in our other educational videos, I don't know whether you have gone through that or not. So we have to describe it. We have to take this. It's not just that mass is coming out, we diagnose it prolapse. First, we have to confirm it as prolapse, okay? Then we have to divide it in anterior compartment problems, middle compartment problems, and posterior compartment. So what happens whenever we know that it is a case of prolapse and patient tells some urinary complaints, we get so overwhelmed. We think that's it. But we should never lose touch to the baseline, whatever is the way of taking history. So if we would have taken her history before, only the first person who saw her, that anterior compartment is this, then middle compartment she would have asked her, do you have, before examining, because maybe somebody first saw there was no decubitus ulcers and then they did not bother to ask about bleeding. Okay, but if we are taking history before examination and asking the central compartment compartment symptoms, we would have asked her whether you have postmenopausal bleeding or not. So our mind will work a little differently. So I think this is a very important message that maybe it is a prolapse, but we keep on telling this in all our case discussions, that never ignore it. It might be harboring some other lesions, and we have to go very meticulously, step by step, knowing that it is a case of prolapse, 3rd degree prolapse, Procedentia. This age group is so important because old women are so prone to develop malignancies, like even lung malignancies, even some abdominal cancer, even some ovarian tumor. So you cannot just treat a benign lesion and leave a malignancy inside.
And this case also highlights the importance of transvaginal ultrasound in a case of prolapse.
Yes.
Every time we say that it is a clinical diagnosis, but it may be harboring some malignancy. So it should be routine. As we do pap smear for all cases of prolapse, we should also do transvaginal ultrasound.
So I'll add 2 points here. So the thing should be very clear in your mind that to diagnose prolapse, ultrasound is not required. Diagnosis of prolapse is clinical, but you have to find out other pathologies. One ultrasound, transvaginal sonography, as well as I'll add on to Richard's comment that even when abdominal pelvic, because we are working so close to that area, like we have to do it, okay, when transvaginal sonography, or if you can combine, because we have to see kidneys also, okay. So one TVS and one full abdominal scanning should be a must, not to diagnose the prolapse. Clinical diagnosis of prolapse is understood, but you have to rule out other pathologies. We should not miss. And second thing, very important, which I said here, is about pap smear. So I want to discuss this also. Usually if you ask students, they will say that, no ma'am, she's more than 65, I did not do a pap smear. So is it required to do a pap smear?
If she is on continuous follow-up of pap smears, then there is no need to do a pap smear after 65 years. But if she has come for the first time and there was not any pap smears done previously, should definitely do a pap
Very
smear
good.
to rule out cervical carcinoma.
And sometimes it might pick up. In patients, it has picked up even endometrial CA. Okay, so very important test. So we cannot go by European and American guidelines. Our country, the scenario is totally different. We do not have a protocol for routine screening of cervical cancer. It is called opportunistic screening. So those women who have regularly and religiously undergone screening with pap smear, they do not require, and every test has come negative. They do not, you can stop their screening at the age of 65. But if a lady is coming to us at the age of 70, 75, we have to do a pap smear because we might detect some abnormalities, and we had cases where we have been able to detect.
And her pap smear report has come as NILM, and in the TVS findings, ET was 14 mm, and there was.
So what will you do if ET is 14 mm?
We have to do a diagnostic endocell and send it for HP, histopathological examination.
So was it done?
Yes, ma'am. Histopathological examination was done, and it has come out as endometrioid adenocarcinoma, and PICO stage grade 2.
Grade 2.
Mrudhula, summarize the case.
Yes, ma'am. She is 74-year-old post-menopausal woman with nil comorbid conditions, with post-menopausal bleeding, and with procedentia of the uterus, with histopathological finding of endometrioid adenocarcinoma, FICO grade 2.
So what next?
So next we have to plan for the treatment of the patient, and for this we need one higher imaging studies to know whether there is involvement of the other organs in the pelvis, or there is any abdominal involvement, and lymph nodal involvement also we have to consider. We'll do MRI to know the tissue spread in the tissues, extent of
biometrical
spread.
involvement,
Yes, extent
and
of
then the lymph nodal involvement.
So I hope you know the difference. Whenever we want to have a bird's eye view, we have to do CT. Okay, and whenever we have to see extension into soft tissues, like here we have to see endometrial cancer, whether it has gone to myometrium or not, we do MRI.
So did the patient undergo MRI?
Yes, ma'am. The patient underwent MRI, and in the MRI also it has come as there are features consistent with malignancy, and it is corresponding to FICO 1B, where there is more than 50% involvement of the myometrium, and there is no lymph nodal involvement.
So now this patient is uterine procedentia with endometrial CA grade 2 and stage 1. Stage 1B. So how will you manage this?
Suddenly one thought came to my mind, how are her kidneys? Because you said that she had anuria, or I won't discuss that.
And her RFT is normal, and even her kidneys are normal.
No
in the MRI.
hydronephrosis.
No hydronephrosis or
But she presented with urinary symptoms.
Urinary
Inability to pass
symptoms.
urine.
So she was not having anuria, she was having retention.
retention, urinary retention.
Yes. So urinary retention can be there because of obstruction due to prolapse or cystocele also. So which I was asking, how will you manage? What is the management? Now it is a difficult case. Normally, if it is a simple case of prolapse, you do vaginal hysterectomy and repairs.
Yes.
And if it is a case of C endometrium, what do you do?
We'll do abdominal THBSO along with staging, surgical staging. For lymph nodal sampling we'll take, and for grading of these tumor we'll do surgical staging.
So surgical staging we do abdominally. Now this is a combination of two problems. Prolapse, Procedentia, that requires management. She is having symptoms also, so management of cystocele also is required. And now she has C also, where you have to do lymphadenectomy. Hysterectomy, tell me what hysterectomy you want to do for endometrial CA? Is it simple like what we do for benign cases or vaginal prolapse cases?
We have to consider whether there is lymph nodal involvement or not, and then only proceed. If there is lymph nodal involvement, we have to do lymph node dissection of the pelvic and para-aortic lymph node dissection.
No, before that, Mrudhula, there is a difference between how we do hysterectomy for a benign disease versus a malignant disease. Whenever we are doing a hysterectomy for malignant disease, it is always extrafacial hysterectomy. While we are doing for
benign, it is intrafacial.
And especially in cases of endometrium, even complex endometrial hyperplasia or C endometrium, we have to remove ovaries also. Okay, so here is the challenge. When we start doing vaginal hysterectomy, it is difficult to approach the IP ligament. Okay, so that's why the management now is lot of discussion. So that's what Richa wants to discuss with you. So how you plan the management? You have to consider both the things. We cannot leave cystocele also because she has symptoms related to that. Those were a major complaint.
As this patient has both endometrial carcinoma and prolapse, we can do vaginal approach, but it is difficult because we need to do bilateral salpingo-oophorectomy also. And if there is expertise to do that, and if they can do that, we can do vaginal hysterectomy. And lymph nodal sampling, beyond stage 1, we can do lymph nodal sampling, but as it is stage 1, we have to decide the benefits and risks associated with lymph nodal sampling. If we can also do abdominal approach, in which we can do surgical staging as we do for endometrial carcinoma, and we can do THBSO. We can also do vaginal hysterectomy, laparoscopy assisted vaginal hysterectomy with bilateral salpingo and lymph node dissection.
So first question is, what are the indications of doing lymph node dissection? So one is lymphadenectomy. Complete lymphadenectomy maybe is required for patients who have lymph node positive. But still there will be some patients where MRI shows that MRI negative lymph nodes, but actually there is some metastatic tissue. Okay, you understand my question? So can you tell me what is the incidence of this kind of where by MRI or clinical it looks like lymph nodes are not involved, but in reality lymph nodes are involved. So around what percentage of people will have this?
Involvement, it will be there in 10% of the
10%,
cases.
correct.
And when there is more than 50% of the myometrial involvement, and if the lesion size is more than 2 centimeters, and histopathologically, if there is a proven carcinoma.
No, proven carcinoma is okay, but if the grade is more than 2. So if I have to summarize the indications of lymph node dissection, one is total lymphadenectomy, which is done for when MRI shows that lymph nodes are involved, then we have to go and do pelvic lymphadenectomy and periaortic lymphadenectomy. I'm not a gynec oncologist, but whatever my knowledge is, I'm telling you based on that. If you feel free to tell me if I'm going wrong somewhere. Then second thing is we have to do pelvic lymph node dissection or sampling of pelvic lymph node in 4 kind of conditions. So one where there is suspicion of lymph node. There are sometimes subcentimetric lymph nodes, but MRI finding says that it is suspicious of metastasis in that case. Second thing is the tumor size is more than 2 centimeters. If cervical glandular involvement is there, then if the grade of the tumor is
2 or
more than 2, and if myometrial invasion is more than 50%. These are the 5 indications where you should go for lymph node sampling. Why we have to go for lymph node sampling? Because these are the patients who will have actually lymph node. They have more risk of having lymph node involvement in histopathology. Maybe MRI or clinical diagnosis is not showing it, but if you see the histopathology, most of the times they will have higher grade or higher stage of disease. Okay.
Then these are the approaches, and to improve the survival rate of the patient also, we can do lymph node dissection, because there are studies telling that survival rate of 5 years is more in patients whom we have done lymph node dissection.
Yes, and graded them properly and maybe given adjuvant therapy accordingly.
That is basically to diagnose early diagnosis of stages.
Mrudhula, there is one surgery where vaginally only you can do vaginal hysterectomy. People do it. Okay, vaginal hysterectomy and lymph node pelvic lymph node dissection. What is that surgery called?
It is Short-Smear surgery.
Short-term patient. She has totally made it British. Then once actually I was called some 3-4 years ago, I was called from oncology department, and they were planning to treat. They had this kind of case with prolapse and endometrial CA. So they had not sent us consultation. They thought that they will deposit it back and do abdominally everything. But when she was admitted, they could not deposit that mass. It was incarcerated prolapse. Okay, so then they needed our help because for vaginal hysterectomy. So it was not possible to deposit. So we did repairs and this thing, vaginal hysterectomy from below. and then they went ahead and did what do you call as lymphadenectomy from abdominal root. That is also one of the things you can do. And sometimes there are reports when the patient has lot of comorbidities. Then you can just give radiotherapy also. That is palliative kind of treatment for endometrial cancer. But I think this patient is fit to undergo surgery. One thing in your examination I would like to tell it to. So though it looks very fascinating, but we should avoid using words which are unique. So you use some word for balls of vagina were thick and tough.
Yes.
Thick and tough means maybe we can use the word of hard. Usually. Okay, hard. So that gives a better impression. That's it. Now Dr. Richa will summarize what we learned from this case.
So this was a case of 74-year postmenopausal lady with uterine procedentia with endometrial cancer. So it was a hidden diagnosis which we evaluated through TVS, and now the challenge is to manage the patient because she has both procedentia and endometrial cancer. So the various approaches we discussed. First is we can do a vaginal hysterectomy, and abdominally we can approach the lymph node dissection part either laparoscopically or open approach, or we can do it vaginally only by doing the Shorter-Mitra operation, or we can do totally abdominally, removing the uterus also from the abdominal root as well as pelvic lymph node dissection.
And after that she will require some adjuvant radiotherapy because it is already it is beyond the 50%, more than 50% of myometry is involved. And whenever we are doing vaginal hysterectomy, we have to do repairs also, because especially cystocele, because she had urinary retention. She went into total retention once, so it's better to treat her.
And take home message from this case is always rule out cervical carcinoma and endometrial carcinoma and ovarian carcinoma in patients of prolapse also.
Yes. So I think it was an interesting case for us to discuss, but maybe not that interesting for the patient. And we have to create more awareness. For so many days, this patient did not go to hospital. And when I was discussing with her patient party and the doctors, then I came to know that actually she went for lipoma. You only told me, Mrudhula, this thing. She went for lipoma treatment when then the doctor saw that the uterus was hanging outside. So lipoma was bothering her more. And maybe this is the primary physician, that person where the patient goes first. We have to have a holistic approach of the patient and see everything and evaluate, and never tell a patient we should that it is just a part of aging. Then next time patient is so embarrassed and doesn't want to tell it to a doctor, maybe the first time when how we treat it. If it's okay that if we do not have the expertise to manage that patient, at least refer the patient timely to a higher center or to a person who can manage it. Okay. I think with that we can stop today's discussion. Thank you, Mrudhula.